Good afternoon. My name is Michal. I'm a cardiologist in the Tel Aviv Sourasky Medical Center. I would like to present the prediction of acute postoperative left ventricular dysfunction, status post mitral valve repair in patients with severe mitral regurgitation. And the thought for the research was that mitral valve regurgitation is a very common valvular disease. It's the second most frequent valve surgery in Europe and in the Western world. And mitral valve repair itself is a very safe and effective and the most recommended surgery for patients with severe primary, which is degenerative mitral regurgitation. However, it is also associated with decrease in the left ventricular ejection fraction status post the surgery. And the mechanism of the left ventricular dysfunction is thought to be multifunctional with the three main ways. One of them is the preoperative, which is, of course, the primary degenerative mitral regurgitation is a chronic, long-standing disease with the left ventricle is need to deal with volume overload for a long time. The second one is the operative, which also include the myocardial injury due to the cardiopulmonary bypass, and also by discontinuation, the continuity of the leaflet and the caudal and the papillary muscle, which this becomes less relative since most of the surgeries that are done today are repair and not replacement. The last one is the post-operative stage. Due to cessation of the retrograde flow into the atrial, which is a compartment with low resistance, so what we have before the surgery, the total stroke volume is composed of both the forward stroke volume into the aorta and also the regurgitant volume. And in the post-operative stage, the total stroke volume is only composed of the forward stroke volume. And if what we can see here is a patient before the surgery. Just a second. We can see a very severe mitral regurgitation. And his ejection fraction and systolic function is a little bit, it's normal systolic function. And this is in the postoperative stage. We can see that the mitral regurgitation was resolved. And if we look at the systolic function, we see a reduced systolic function in this patient. So for today, currently the guidelines I mentioned in the European guidelines are the defined severe mitral regurgitation by quantitative parameters by the echo, which include first the effective regurgitant orifice area, which is a EROA, over 0.4 centimeters square. Second one is the regurgitant volume himself, the RVOL, more than 60 millimeter, and also the regurgitant fraction, more than 50%. However, those parameters are not used for the decision for the operative intervention, and are also, we don't know their prediction of postoperative left ventricular dysfunction. The only echocardiographic parameters in asymptomatic patients, of course, are the left ventricular ejection fraction lower than 60%, the left ventricular end systolic diameter more than 45 millimeters, and if they have a systolic pulmonary artery pressure more than 50 millimeters. So the aim of our study was to try to evaluate if there's any association between the quantitative parameters of the EROA and the regurgitant volume as predictors of the development of acute postoperative left ventricular dysfunction. And also by evaluating this and finding a connection, this may help us decide the timing of the surgery in asymptomatic patients. So it was a retrospective single-center observational study in the Tel Aviv Sourasky Medical Centers, included with all patients with severe primary degenerative mitral regurgitation that went mitral valve repair in the years 2007 to 2015. All patients underwent echocardiographic examination before and after the surgery during their hospitalization. Excluded were patients with secondary mitral regurgitations or undergoing mitral valve replacement. We did include patients that were going concomitant surgery like coronary artery bypass, other valve surgery, or MACE. We divided the patients into two groups by defining them as all patients were severe MR, of course, because they went for surgery. So we divided them by severe MR and very severe R. First time by the ERO over 0.6 centimeters square, and the second time by regurgitant volume over 80 milliliters. Our outcomes were either a postoperative left dysfunction with evaluated as ejection fraction less than 50%, or the delta AF, the change before the preoperative ejection fraction minus the postoperative ejection fraction. We had total 145 patients. 62 of them were excluded due to secondary MR and MVR. And totally we got 83 patients who we divided and evaluated in two groups. First by ERO over 0.6 centimeters square, and second time by regurgitant volume over 80%. In both groups, the patients were almost 50-50 equal. So the first group was the ERO group with ERO over 0.6 centimeters square. In the basic characteristic, we find no differences in age, male, in chronic disease, and also differences in other surgery performed. When we evaluated the outcome, we saw that the preoperative ejection fraction had no significant difference, but also we saw in this group that there was no significant difference in the postoperative ejection fraction. However, we saw more frequently LV dysfunction with ejection fraction less than 50% in the very severe MR group, and also the delta was higher in the very severe MR group as well. To repeat that, we saw no difference in the preoperative ejection fraction, which is very important. There was no significant in the postoperative EF, but it was more frequent LV dysfunction and higher delta EF. In the second group, the regurgitant volume over 80 milliliters, we also had no baseline characteristic differences. And in these results, we saw that in this group, the preoperative ejection fraction was not significant, but here the postoperative ejection fraction itself was significant, as well as the percentage of left ventricular dysfunction and the delta of the ejection fraction. And this is to conclude this again. Here, the postoperative ejection fraction was also lower in the very severe MR group. We also did a multivariable analysis which found that the regurgitant volume was more stronger than the EROA and also was significant the preoperative ejection fraction. Since the end systolic dimension is also a part taken for decision for intervention, we did also a multivariate analysis including the end systolic dimension and found that the regurgitant volume was still significant. So for conclusions, we found that a patient who defined very severe MR by regurgitant volume of more than 80 millimeters are associated with developing postoperative LV dysfunction after mitral valve repair. This might be an helpful parameter for making a decision for the timing of the intervention in asymptomatic patients. The limitations of our study was first that it was a single center, small number of patients and retrospective study, but of course we need also to evaluate the long-term function of the ejection function. Since the echo was performed at the acute postoperative stage only during the stabilization and not afterwards, and also of course evaluating the outcome of survival. Thank you.